Welcome everyone to our webinar today. A few housekeeping items before we get started. In today's webinar's agenda, we will talk about the importance of annual screening in patients with von Hippel-Lindau, what has to be screened, and possible consequences for the patient. Thanks to VHL Europe for making this webinar possible. They chose the topic and also invited the speaker. This webinar will be recorded and we will send out the YouTube link as soon as possible to all the people who have registered. It will be also posted on the VHL Rare Connect community. A few reminders before we get started. Audio will be made available through your computer speakers. Due to the large number of participants, we will be muting all the microphones during the webinar. Please feel free to ask questions at any point during the presentation using the Q&A button located at the bottom bar of your screen. We will reserve some time at the end of the presentation to answer your questions. We will do our best to answer as many questions as possible throughout today's event. If you're having difficulties viewing the PowerPoint presentation, please make sure you have a stable internet connection. The audio quality might also be better if you use headphones. And with that, we will open today's webinar. We are very lucky to have with us today Dr. Marie-Louise Binderup, a postdoc researcher at the University of Copenhagen in the Department of Cellular and Molecular Medicine. And with that, let's start. Marie, would you like to open for us?
Yes, thank you. Thank you for the introduction, Martha. And I'm very happy to have been invited to do this webinar, and I'm excited to see how it works. Usually I talk in front of people so I can see the reactions of the people I talk to. So I'm excited to see how this works. As Martha said, I'm a researcher at the University of Copenhagen. And I've been doing research in von Hippel-Lindau disease for about 10 years now. And my main focus has been on this topic of screening and trying to improve screening for von Hippel-Lindau patients. Okay, it works. Okay, for my talk today, I will start with some background about the disease so we're all on the same page. I'll start by telling you a bit about the clinical characteristics of the disease, and then I'll talk a little bit about the genetic aspects of the disease. Then I will move on to today's topic and talk about the screening recommendations for von Hippel-Lindau patients. I'll start with telling you why we screen, when we screen, and how often we recommend screening. I'm from Denmark, so I'll talk about the Danish recommendations and our experience with VHL screening in Denmark. And then I'll talk a little bit about the recommendations in other countries and how they compare to each other. And then in the end, I will focus a bit more about what I see as the future of von Hippel-Lindau screening, that is a more individualized screening. I'll show you some of the results of my research, which is mainly focused on which factors influence tumor development. So first, the clinical characteristics of the disease. The disease was first described by Dr. Eugene van Hippel in 1911, and he described these characteristic hemangioblastomas of the retina of the eye. But it wasn't until 1926 when the Swedish pathologist Dr. Lindau discovered that similar lesions in the brain were associated with these von Hippel lesions, and he also discovered that they're also associated with many other different manifestations, and therefore the disease is named after both of these doctors. When you are predisposed to VHL, you're at risk of developing multiple tumors and cysts in many different organs of the body. And on this slide, I will show you some of the manifestation frequencies in VHL populations. So I'll show you how many patients in different populations on average have this manifestation. And by manifestation, I mean tumor type. So the most common manifestations are the retinal hemangioblastomas of the eye. And as you can see here, on average, it's about 50% of patients who have these manifestations. But there is quite a variation, as you can also see. And this is one of the things that is with this disease, that there is quite a bit of variability in which types of tumors patients have. Also very frequent are the hemangioblastomas in the cerebellum, and which is also about 50% of patients who has this. The hemangioblastomas can also be found in the spinal cord. And another serious complications is the kidney lesions, which are kidney cancer, renal cell carcinoma, but also renal cysts, which may be benign, but which may also develop solid lesions that can lead to cancer. There's also a risk. There's also a risk of developing pheochromocytomas, which are hormone-producing tumors that occur in the adrenal glands. In the pancreas, there's a risk of cystic development, but also development of neuroendocrine tumors, which can also become malignant. Some patients also develop cysts in their reproductive organs, and a few develop tumors in their inner ear, also called the endolymphatic sac tumors. Many of these tumors don't cause any symptoms at first, and sometimes they won't cause symptoms before they've grown very large and before they've created some permanent complications for the patient. Genetic aspects of the disease. So actually what causes this disease? Here I show you a slide showing all the chromosomes that we all have in our body. There are 23 pairs, and the VHL gene, which is in many cases, the disease is caused by a mutation in the VHL gene, and this is located on chromosome 3 that you see here. So if you have a predisposition in one of your copies of your VHL gene, you will have a mutation. And here you see the gene up close. It's a small gene consisting of 3 exons that translates into a protein product called the VHL protein, or PVHL. And here I'll show you a little bit more about the VHL protein, because the VHL protein has many different functions in the cell. But one of the most best known functions, and one of the ones that's believed to be important in VHL tumor development, is the protein's role in the oxygen sensing pathway. So basically how it helps the cell sense if it has enough oxygen to perform its functions. So under normal circumstances, if the VHL gene is not mutated and if the cell has enough oxygen, then the VHL protein is part of a complex with other proteins. It's called a ubiquitin ligase complex. The function of this complex is to recognize a group of other proteins, a group of transcription factors called HIFs, which stands for hypoxia-inducible factors. So the complex binds these HIFs and marks it for degradation. And so it's destroyed by the cell. So under normal circumstances, the HIFs do not get to perform their function. But if the cell lacks oxygen, or if you have a mutation that causes that you don't have any VHL protein, any functional VHL protein, then it cannot perform its normal function. The HIFs are not degraded, but instead they are located in the nucleus, and where they initiate transcription of several different genes, many of which are involved in blood vessel formation and in cell survival. So basically, if you have a mutation in your VHL gene, the cell reacts as if it needs oxygen, as if there's a lack of oxygen, and it reacts by creating more blood vessels to transport oxygen to the cell. And this is part of the explanation why you're at risk of creating these these hemangioblastomas, especially, which consist of mainly of blood vessels. So today's topic, prophylactic screening. I just want to say that it's also usually referred to as surveillance, and you'll hear me say surveillance a lot in my talk today because that's what I usually call it. And why do we screen? When do we screen? And how often do we screen? I'll get to this now. So first of all, why do we screen VHL patients? Well, as I showed you before, there's a risk of developing these multiple different tumors. The problem is we don't know when the tumors will occur or if they will occur at all. And at present, there's no pharmacological treatment, so you can't take a drug that will prevent the tumors from developing. And so our only option now is to treat the tumors by surgically removing the tumors. And this is best done if the tumors are found at early stages so that we can better plan the intervention, and in some cases so that the tumors can be treated right away. And we do this by screening. In relation to screening of VHL patients, it's very important to remember that it's a fine balance between trying to find the tumors as early as possible to be able to best prevent complications from the disease, but also a balance in not screening too much so that it puts a lot of strain on the involved families. It gives a lot of anxiety having to go to examinations all the time. So it's really a very delicate balance when we do this screening. The Danish screening recommendations, which I know best here, I'll show you as an example, and I'll show you some from the other countries as well afterwards. But in Denmark, we recommend from birth that you have an annual clinical examination by a pediatrician. Especially the pediatrician should note the patient's blood pressure, of course, but also a neurological examination of the child. We also recommend ophthalmoscopy, that is an eye examination, as early as possible. And we do this in very, very young children, and because the children are so small, it can be hard for them sometimes to cooperate, and therefore we recommend that it is an ophthalmologist who specializes in children who does these examinations. From 5 years of age, we also recommend an annual blood test to look for metanephrine and normetanephrines, which are products of these pheochromocytomas. We also recommend an annual hearing examination to screen for the endolymphatic sac tumors. And then in childhood, we also recommend that patients have a baseline scan, both of the CNS, so that's the head and the spinal cord. And this is preferably done in the interval between 8 and 14 years, because we know that in this interval, some of the children will begin to develop tumors of the CNS, but also they are more likely to cooperate to be able to lay still in the MRI scanner, and you don't have to sedate them, which you may have to do if it's very small children. In childhood, we also recommend a baseline ultrasound of the abdomen. Then from adolescence, we say 15 years of age, we recommend an annual neurological examination and regular scans of the CNS and the inner ear. And we've put the frequency to every second year. We also recommend that you have regular, that is annual examinations of the abdomen. And we recommend alternating with ultrasound and MRI. So the year that you have your MRI of the CNS, the abdomen is also scanned. And the year that you don't have your CNS MRI, then it's ultrasound of the abdomen. So I'll talk to you a little bit about how we do this surveillance here in Denmark. So the surveillance recommendations are formulated by the Danish VHL coordination group, which I'm also part of, which is a group consisting mainly of doctors from different specialties, which are involved in von Hippel-Lindau disease, but also representatives of the Danish patient organization, who's actually been a big part of making this happen. And the coordination group has formulated these surveillance recommendations. And it's important to say that these recommendations are based on expert judgment. I mean, this is experience from treating von Hippel-Lindau patients, as well as experiences from the literature. So it's not an exact science, and as I said before, it's very much a balance between doing enough examinations to prevent complications, but also not doing too many examinations to strain patients unnecessarily. So in Denmark, we've realized that it takes a lot to coordinate all of these many examinations that are recommended. And we've actually recommend that one doctor, one of the patient's doctors, takes the lead and becomes the clinical coordinator. So this is a doctor that the patient sees each year, and it varies whether in the different places in Denmark, whether it's an ophthalmologist, it's sometimes a clinical geneticist, sometimes it's a neurosurgeon, but a doctor who takes responsibility for these examinations and makes sure that the patient has had all of the different examinations at the recommended frequencies, because that's usually a problem to make sure that examinations are not missed. And recently, or in the last couple of years, we've also done this in Denmark, in some areas in Denmark, that we've have these multidisciplinary clinics, especially in Aarhus. We have a multidisciplinary clinic running. So this is a clinic where we try to coordinate as many as the patient's examinations in one day as we can. So usually the way it goes is that the patients have a blood test and imagings done beforehand, and then they come to this multidisciplinary clinic and they see first, for example, an eye doctor first, and this doctor will do the eye examination. Then you go to the endocrinologist to get your results of your blood test. Then you see a neurosurgeon to get the results of your imaging and also to do the neurological examination. You go and get your hearing tests. And if you would like, then you could also talk to a clinical geneticist if you have any questions. And we try to organize it so that family members can go on the same day. And it's our impression that this really improves the quality of life for the patients, because instead of having to take several days off of work, you can do as much as possible in one day. You also don't have to, usually if you have many different examinations all over all throughout the year, then you will have, studies have shown that you will have anxiety each time you go to have an examination and you wait for the result. So hopefully this reduces it a bit. So that was what we do in Denmark, and now I'll talk a little bit about the recommendations in other countries. And I'll take them one by one, and I'll take some of the most important of the screenings in my opinion. So first, the screening for the retinal hemangioblastomas, which as I said is ophthalmoscopy and dilation. And here I've included, of course, the Danish recommendations that you just saw, and also the German, the Dutch, the English, and the American recommendations. And for the eye examination, everyone agrees that the best frequency is annual examinations, but the time at which the examinations start varies a bit from country to country. So in Denmark, in the UK, and in the US, we recommend a very early start, while in Germany and the Netherlands, 5 years is the lower limit. And it can be discussed whether which starting point is the best point, and I think we could have a discussion about this in the end. For the CNS hemangioblastomas, that is the MRI of the head and the spine, there is also a bit discrepancy in when we recommend to start. Most countries recommend about 15 to 16 years. And in Denmark, as I said before, we also recommend that there's a baseline done at between 8 and 14 years of age to make sure that there are no pre-existing hemangioblastomas that should be dealt with before the regular screening starts. And in Germany, it starts at 10 years. The frequency of when the examinations start is also a bit different in different countries. In many countries, it's every second year, but in some countries, it's every third year. It's important to say, both for this type of screening, but also for the other recommended examinations, that of course this screening assumes that the patient has no symptoms. So if the patient has symptoms, for example, has neurological symptoms, then the recommendations for the very young, oh sorry, I just saw something else. I'll try again. So the recommendations, if you have if you have symptoms, will of course be different than the recommended screenings, because if you have symptoms, then it's a sign that there is a tumor that needs to be dealt with. And the same goes for if you know that there are hemangioblastoma, or if there is a kidney tumor that needs to be looked at closer or be kept an extra eye on, the frequencies may also be lower than maybe every year or every 6 months instead. For pheochromocytoma, it also varies a little bit if it's recommended to do a blood test or if it's recommended to do a urine analysis for these hormones and their metabolites. But everyone agrees that it should be an annual examination. In Denmark and Germany, it's 5 years. In the Netherlands, it's 10 years. And in the US, it's also 5 years. For the abdominal imaging to screen for renal lesions, pancreatic lesions, and also pheochromocytomas is also annual in all of these countries. But the time at when you start is also a bit different. 10 years in Germany and the Netherlands. In Denmark, 15 years for regular examination, but also a baseline before 15 years of age. It's also a little bit different if you recommend ultrasound or MRI, or if it's alternating ultrasound or MRI, as you can also see here. So now I'll talk a little bit about the individualized surveillance, which I see to be the future of VHL surveillance. As I said, my research has very much revolved around this topic. And the reason why everyone now are recommended to do the exact same surveillance program, regardless of individual factors, is that the major problem with VHL is that VHL disease progression is extremely variable. So this means, as things are now, we're not able to predict who will get the different types of manifestations, or when in life the different manifestations will occur. We are learning more and more, and hopefully in the future, I think that we will be able to do a more individualized surveillance based on individual risk factors. So my research has mainly focused on these, which factors influences VHL tumor development throughout life. And here I'll tell you about some of the results from that age actually has a big impact on tumor development, the type of mutation that you have in your VHL gene, but also the sex, that is, if you're a male or if you're a female. So first, with age, we have found in our research that tumor development varies with age, but it also varies differently according to where the tumor is located. And I'll show you this here. So here I'll show you some results of a study we did trying to find out when in life retinal hemangioblastomas are most frequently diagnosed. And this graph here, you can see on the x-axis you have the patient's age in years, and on the y-axis you have the number of new manifestations diagnosed each year. The blue line here represents the rate at which new manifestations are diagnosed, and the red lines represent the confidence interval. And as you can see here, the tumors develop at the highest rates in patients' teenage years. This corresponds to about 1 new tumor every 2nd year. And if we compared the rates here in the teenage years with rates in younger and older ages, the rates were actually significantly lower at these ages, and corresponding to about 1 new tumor every 10th year here in adulthood. So this underlines for me that it's especially important to go to these eye examinations in your teenage years or in childhood, but it may be relaxed later in life. The problem right now is that we don't know exactly which patients are the patients, or which risk factors, that was a hard one, which risk factors do the patients who actually develop these retinal hemangioblastomas in adulthood have. So this is a similar graph for the hemangioblastomas located in the cerebellum. Here again, on the x-axis you have the patient's age in years, and on the y-axis you have the number of new manifestations per year. And in contrast to the retinal lesions, you can see here that the highest rates were in adulthood from around 40 years of age. And this actually also corresponds to a rate of about 1 new tumor every second year. And compared to rates at the younger ages, these were significantly lower. So this emphasizes that even though it's the same kind of tumor, it's hemangioblastomas both in the retina and in the cerebellum, here it's especially important to screen in adulthood. And this actually also corresponds with some of the current recommendations. One of the things that we've actually known for a while is that the type of mutation you have in your VHL gene has a great effect on which kinds of tumors you are at highest risk of developing, but also when in life you're at highest risk of developing these tumors. When we say genotype, we mean, as I said before, the type of mutation that you have in your VHL gene. So far, there are more than 700 different mutations found in the VHL gene. So of course, we have to look at them with a broader view. So in general, we divide the mutation types into two main groups. The missense mutations, which are alterations of just one building block of the DNA in the VHL protein. It usually leads to an altered VHL protein, but in some cases it may still have some residual function. So it may function a little bit in the cell, but not normally. Then there's the truncating mutations. These are different kinds of mutations, but in general it's mutations that are a little larger than the missense mutations, and they usually lead to the result that there's no VHL protein at all left in the cell. Oh, and before I move on, I just want to say that it's been known for some time that especially for missense mutations, if you have a missense mutation, it's known that you are at higher risk of developing pheochromocytomas. And we actually also found out that if you have a missense mutation, you're also at higher risk of developing retinal hemangioblastomas, while if you have a truncating mutation, you're more at risk of developing tumors in the CNS. Here again, I'll show you a graph similar to the ones we saw before, but here with the genotype. Again, here on the x-axis, you have a patient's age, and on the y-axis, the number of new manifestations diagnosed each year. In blue, you have the manifestation rate for patients with truncating mutations, and in red, the manifestation rates for patients with missense mutations. And as you can see, the rates are quite similar until the age of 20, when the risk of new tumors is higher for patients with truncating mutations. And this is all types of VHL manifestations that are included in this graph. But when we looked at it more closely, it was especially the hemangioblastomas of the brain that caused this, this difference in tumor risk. And overall, it was actually almost twice as high risk of new tumors if you have a truncating mutation compared to if you have a missense mutation. But again, this is just, there are exceptions to this rule. This is just if we divide into these very broad groups. So there's still some way to go before we can use this to individualize the screening. As I said before, we also looked at the effect of sex, and we found that men tend to develop new tumors faster than women in adulthood. Again, here a similar graph with the age on the x-axis and the number of new manifestations per year on the y-axis. Red is the female manifestation rate, and blue is the male manifestation rate. And as you can see, they're also quite similar until adulthood here, about 30 years of age, where the male patients actually have a higher risk than the female patients. It's not quite accurate, the graph, when we come to these high ages, because there weren't very many participants here. So this is not very accurate here in the end, but it was striking for us to see that there was actually a difference if you're male or if you're female. And as I said before, we still recommend that all von Hippel-Lindau patients attend the same screening program. We still can't say who will develop which tumors, and we can't individualize based on these results yet. And it's also important to say that the results I showed you now, these are results, research results done by looking at the Danish von Hippel-Lindau population, so the Danish von Hippel-Lindau patients. There might be other factors in other populations, so it might be different in other countries. There may also be other factors, or there's quite certainly other factors that we haven't looked at yet. There might be other alterations in other genes that we don't know about that may affect the way the altered VHL protein works. We know that even in the same family where patients have the same kind of mutation in their VHL gene, there can be very big differences in how the different family members, how the disease progresses in the different family members. So it's still not an exact science, but I hope that we will be getting there. And the most important thing is to keep on doing this research and also trying to do it in as large VHL populations as possible. That was it for now, and before I answer question, I would just like to acknowledge that, of course, I didn't do all of this work myself. I work with Marie-Louise Bisgaard and Esben Butz Jørgensen in our research group, as well as many others. And I work together with, of course, the Danish VHL coordination group. And I'm also very closely supported by the Danish Patient Association, and especially I'm inspired, and I couldn't have done any of this without the help of all the wonderful VHL families who participate in our research. So thank you for that. And now I'll answer questions, and I think I need your help, Martha, to see.
There's a question on the chat.
On the chat, oh, yeah, okay.
Yeah.
And everyone can see this, right? So
yeah, it's from user K80, I think.
Okay, and it says, for very young affected, less than 18, with no CNS symptoms, my neuropsychologist suggests MRI without contrast medium. She says she can see lesions from 2 to 3 millimeters even without contrast medium. Oh, I pushed the wrong button here. I'll just let you see the recommendations while I answer. So this thing about contrast has actually been a topic that's been up recently because, of course, some patients are not able to have too much contrast medium because they may have affected renal function. But we do recommend contrast in these scans regularly if you don't have any problems with your kidneys, because even though you may be able to see lesions from 2 to 3 millimeters, I think that's impressive. There may be even smaller lesions. For example, the lesions that we see in the inner ear, the ELST tumors, can be even smaller. There's also a recent study about contrast from the German group that's shown that the contrast that's most commonly used can actually be seen to accumulate in some parts of the brain. But there's no evidence if this makes any difference. It usually doesn't. For now, we don't know that it causes any problems for the patients, but there is certainly a focus on this contrast. So I think we'll see more about this in the future. I hope that answered the question.
Okay, is there any other question? Now is the time to ask them, you can use the Q&A button or write them in the chat if that's more convenient for you. Okay.
I must have been very clear then.
Yeah. If you have a question, maybe tomorrow or next week, you can send it to email to me at info@rareconnect.org, and we can send it to the speaker, and maybe she can answer it maybe later.
Yes, I would do that. I can see in the chat there's someone who asked if we send out slides.
Yes.
Yeah.
Sorry. Go ahead.
Well, it's being recorded, as you said, and put on YouTube. But if you would like the PowerPoint slides, I can send them directly to your email as well. You can give Martha the details.
Yeah, I'm going to send an email to all the people that have registered with the link of the recording and then also the slides if you want to share them with the participants.
Yes.
Perfect. So unless there are any other questions, I want to thank Dr. Binderup for her presentation and everyone who has participated on today's call. As I said, everyone that registered will receive an email with the webinar, probably next Tuesday or next Wednesday, because I have to download and edit the video. So thanks everyone for your patience and your participation, and have a good afternoon.
Thank you.
Thank you. Bye-bye.